to receive you here today. And I'm going to introduce yourself. I'm going to change to Portuguese just to introduce yourself for the whole teammates that are here. And then I change again to English for you. Bom, pessoal, então, só para introduzir aqui a doutora Annette Brutfield, que é professora de nefrologia da Universidade de Linköping e do Instituto de Karolinska, na Suécia. É um prazer a gente recebê-la aqui para ela falar hoje sobre tratamentos biológicos emergentes e terapia-alvo na vasculite ANCA. Queria só sinalizar a vocês que no nosso chat a gente está com um typeform, um formulário ali para vocês clicarem e colocarem ali, por favor, o dado de vocês. E quem for aqui da DaVita, esse formulário vai ser importante aí para a gente poder gerar o certificado aí de educação continuada, tá? Então, peço para a gentileza de quem for aqui da DaVita, por favor, preencher esse formulário. So, Annette, we are with a high number of nephrologists here from all over Brazil and from other places too. This is our monthly session from DaVita, and please, you are our guest today, so be free to give your talk and have a good class. Thank you very much.
Thank you so much for the invitation. So I want to share my presentation and see how it, if you can see it now.
Yes, now it's okay.
Okay, so I changed the title a little bit. So, I will talk about future perspective. It's on the update of current treatment in ANCA-vasculitis and future perspective. So I have some disclosures. So what are the goals of treatment in ANCA-vasculitis? So this was a disease that was universally fatal before it was physicians started using immunosuppressive treatment. So patient survival is, of course, very important. And we want to induce remission of active disease. We also want to avoid disease relapse, which is quite common in this disease. But also at the same time, we want to minimize treatment toxicity. And in ANCA-vasculitis, infections are very common. And also reduce organ damage, especially end-stage kidney disease. All these goals, while trying to reach them, we want to optimize the quality of life, and the quality of life of these patients is reduced. And the long-term goal is to personalize treatment. Instead of treating everybody the same way, we would like to improve and develop a more patient-specific approach. So the treatment-related adverse events are very common. Infections are always a threat. After diagnosis of ANCA-vasculitis, during the first year, if the patients die, they die more often of infections and less of vasculitis. And this is European data. And especially the patients with a low GFR have also an increased risk of infection, which is, of course, not surprising because what we see in all our patients with reduced eGFR. The risk of diabetes is increased, the risk of osteoporosis increase, and cataract. And all of these are believed to be secondary to the use of steroids. If other drugs that we use are cyclophosphamide, and that can affect fertility and also increase the risk of malignancy. And altogether, all these patients have increased cardiovascular risk in the long term. So what is the incidence and what is the prevalence of this disease? At the beginning, when ANCA was discovered, it seemed like every year there were more and more patients, but it's probably had to do with like a testing effect. But this is data from south of Sweden and showing that the incidence is fairly similar. They test at different time points, and they started already in 97, and they tested right before the pandemic again, but the incidence is almost the same, but the prevalence is increasing, and that has to do with our treatment is improved and that the patients survive. So we have more patients that live with this disease, but that also means that we have more patients who are at risk of relapsing. So in the long term, I mean, we have followed patients for a long time. We have done many studies, especially in Europe, through this European Vasculitis Network. And we have looked at all the patients that we could retrieve in the studies that we have done. And these are, I think, 8 trials from 17 countries in Europe. And you can see here that long-term risk, like the mortality, is still significantly different as compared to the general population. So there is a excess mortality risk of 14% at 1 year and almost 30% at 13 years. And the main causes of death are infection, cardiovascular disease, and malignancy. Negative progressive factors also are, of course, age, male sex, low eGFR, and this is still quite a big issue. The risk for end-stage kidney disease is, of course, also elevated, and this is the same data set showing that factors associated with end-stage kidney disease is age, eGFR, and lower hemoglobin in this data set. So the pathological mechanism of this disease is characterized by inflammatory cell infiltration and necrosis of small vessels. And one very important cell is, of course, a neutrophil that is primed at the beginning of the disease by inflammation. It could be an infection or something else. We are not really sure how this disease starts. Also, complements are important to induce activation of the neutrophil. And here you have the ANCA antigens in the neutrophils. And when the neutrophil is primed, these antigens move to the cell surface and thereby induces the production of ANCA because the body sees this as something strange. So there's this B cell activation and ANCA production, and then eventually the neutrophils will degranulate, and a number of events like proteases will induce inflammation of the vessels, and NETs also can induce inflammation of the endothelial cells, and then they will have activations of other immune cells. So as far as the treatment is concerned, the treatment has developed or evolved during many years. So here, these are the first studies. On the top here are the induction trials, the big induction trials looking at plasma exchange or not, plasma exchange versus high-dose steroids, oral cyclophosphamide versus IV cyclophosphamide. And from here, you have the rituximab story starting from 2010. And also, again, plasma exchange has been studied comparing and also high and low dose steroids. On the bottom here, you have all the maintenance trials that have been done, and there are also ongoing trials. And here, things change also to rituximab that has become for many centers a more standardized treatment, both for induction and maintenance. So what do we mean by biological treatment? So these are biological medications, are drugs that target specific parts of the immune system to treat disease. And drugs, they're manufactured through chemical synthesis with well-defined structures.
Dois hambúrguer, presunto, queijo e...
Oh shit, we're saying English.
I'm sorry, Annette. I think you can continue, no problem. Annette, you are on mute.
Yep.
I think. Okay.
Oh, okay. Yes. Okay.
It was just now or for only now? Okay.
Just for a bit, yep.
Yeah, okay. So an example of the biological medicines of course, the monoclonal antibodies, such as rituximab, but also now with gene therapies and stem cell therapies that are also biological medicines. So the success of B-cell therapy as rituximab has and B-cell depletion and associated vasculitis has led to a growing interest in other treatment targets. And the main ones is complement, and then more B-cell targets, T-cell targets, and cytokines. And I will discuss that. I will just mention briefly plasma exchange. Because that was the biggest trial that was ever done in ANCA vasculitis, the PEXIVAS trial, and this compared the use of plasma exchange versus not using plasma exchange. And then in another study, under the same study, was comparing standard dose glucocorticoids, 1 milligram per kilogram versus reduced dose glucocorticoids. And this study showed that there was no difference between the use of plasma exchange or not, but there was a difference in the reduced dose glucocorticoids arm that showed that the serious infections were less common with reduced glucocorticoids. So the alternative complement pathway has gained a lot of interest in this disease. ANCA vasculitis is a neutrophil predominant vasculitis, and complements induce neutrophil activation. So C5a and C5a receptors is the prime therapeutic target, and because of this, a selective C5a receptor antagonist, avacopan, was developed. The first study that we did was the CLEAR study. It was a phase 2 trial looking at selective orally administered C5a inhibitors in patients with ANCA vasculitis, and they were divided into 3 groups. One received standard of care, another group received reduced dose corticosteroid, and one received no corticosteroids, and in combination with I think it was cyclophosphamide in this trial. And it showed that the patients who received avacopan had a better outcome when disease activity and albuminuria, and also better health rate related quality of life. And this led to the ADVOCATE phase 3 study, which was a double-blind trial looking at patients with standard of care with avacopan or avacopan placebo, which was then standard of care glucocorticoids. And these patients were treated for 1 year. And this trial showed that there was no difference between the groups when it came to remission at week 22, but at 26, but at week 52, the number of patients who were in remission was significantly higher in the avacopan group.
Annette?
Yes.
Can you hear me? Oh, sorry. This is Marcelo. Yeah, I was having audio difficulties, but I'm getting a sense from the chat that the slides are stuck on slide 7.
Oh, that's terrible. Because somebody changed.
I'm not sure.
Really? Should I stop sharing and start sharing again because somebody
I think
took
that's a
over
good
the slide?
idea. Yeah.
Yeah.
Might be a good idea. Yeah.
Let's see. How can I stop sharing? Let's see here. Lyfta dela. Maybe I'll start all over again, but I'll start from where I was, and I'll
Sure.
because I think I could, and then somebody took over sharing the slides. I don't know why.
Yeah.
Something happened.
That's
now
okay.
I'm back. Yeah. I'll just continue where I was. So anyway, the Avacopan trial showed that the use of Avacopan was, but it says here, the publication in New England Journal of Medicine, a game changer in ANCA-associated vasculitis. I don't know the situation in Brazil, but it is approved in Europe, but we still can't use it in Sweden because they can't decide on the price. So we can only use it for compassionate use, which is unfortunate, I think, because it's a very good drug. So the most interesting thing, I think, it's not the that you can exclude the use of steroids and instead use Avacopan in the treatment. That is, of course, important, but the main interesting thing for at least for nephrologists, I think, is the eGFR outcome, because in this study, it was shown that Avacopan was patients treated with Avacopan had a much better eGFR at week 26. And these are all patients with kidney involvement. And here are also patients with 13 eGFR. And here is the patients who had the worst kidney function, lower than eGFR 20 around. But patients with the 15 eGFR, they were excluded from this trial. But it showed that the patients receiving Avacopan, the effect on kidney function was quite impressive, and also correlated with a very quick reduction in albuminuria early on. So can you see the slides now?
Yep. They're moving along fine. Yep.
Okay, so this is also just showing that the reduction of albuminuria, looking at the same data set, we presented this in many ways, that the UACR improved 3 times faster in the Avacopan group compared to the prednisone taper group. So then there are other complement studies, but they have not been that many. There's at least one that I've been active in, and I haven't seen it published yet. But of course, there are several companies who are interested in developing something similar. As for the new studies in ANCA-associated vasculitis, one interesting drug is obinutuzumab, which is a monoclonal antibody that also is directed against CD20 as rituximab, but it has a higher affinity for CD20 antigen binding and also leads to increased direct cell death. And it gives a deeper B cell depletion than rituximab. And it's also humanized, that should be more tolerated. And this is just showing from this phase 2 lupus trial, and now it's been a phase 3 lupus trial recently published using obinutuzumab as an add-on therapy, in this case for lupus. So as far as ANCA-associated vasculitis is concerned, there's one study ongoing in the UK, and this is a randomized phase 2 trial called OBIVAS that is comparing obinutuzumab and rituximab in ANCA-associated vasculitis. So The rationale is that there is a risk of relapse after rituximab discontinuation because of the B cell repopulation, and also that it is believed that B cell persist in the tissue after rituximab. So the hypothesis is by using to deplete B cells on a deeper level will be more effective. And in this trial, 26 patients will be included, so it's like a more mechanistic trial, a small one. And obinutuzumab will be compared to rituximab, and they will be given the same induction therapy, the same dose, and there will also be nasal biopsies at 0 and 6 months to see to look for these B cells in tissue. So I don't know exactly when this trial will be ready, but maybe next year. Belimumab is a B lymphocyte stimulator, BLyS, that also plays a role in lupus. That is where it has been used a lot because of the trials done in lupus. But there has been a trial looking at belimumab for ANCA vasculitis as maintenance of remission treatment. But comparing in this trial, it was not shown that this was better than standard of care for remission therapy. So people have been thinking about this, and maybe they should combine it with something. So here they want to combine it with a B-cell sequential therapy with belimumab, a BAFF antagonist, and rituximab, and maybe this may enhance the B-cell targeting in ANCA-associated vasculitis. So this would be new or relapsing PR3 ANCA-positive patients, and the primary outcome will be time to PR3 ANCA negativity. And I think this trial should be finished, and maybe the results should be presented this year, because the last patient was included a couple of years ago. So that should be interesting to see if this is something that could be used. These are well-known drugs, and that we know how to use already. So what about T cells? I mean, we know that there are T cells in tissue and T cells are activated. So abatacept is blocks CD28 with its ligand containing CTLA4, and thereby inhibits T cell activation. So there was a trial that enrolled 20 patients with a non-severe relapse. The definition of that was, I'm not quite sure. Most non-severe relapse actually evolved to severe relapses anyway. But this is within 28 days prior to enrollment, they were supposed to have a non-severe GPA relapse. And they used it and thought that this was well tolerated, and there was a high frequency of disease remission and also prednisone discontinuation. So then they decided to do a larger trial, and it has not been, sorry. And the larger trial, bigger randomized trial, showed that it was not effective in the treatment of this relapsing non-severe GPA. So we don't really have an answer how we should treat these sort of more grumbling cases who may not have a organ-threatening disease. At least not with T-cell therapy. Doesn't seem like a big hit. So what about cytokines in ANCA-associated vasculitis? And it's known since a long time that TNF inhibitors have a very limited effect in ANCA-associated vasculitis and has not really been used much. Tocilizumab, which is a monoclonal antibody against the IL-6 receptor, is approved for giant cell arteritis. And there has been some case reports showing that this could be effective. And during COVID-19, this was used for severe COVID. And I happened to have a patient who had ANCA-associated vasculitis and also severe COVID, and he was given tocilizumab and did well after that, and even became ANCA negative for the first time in 5 years. So, I mean, it's good that we have some options, but it's not very commonly used. So, when it comes to ANCA vasculitis, we all focus a lot on inflammation, how to reduce inflammation, but then there is also something that happens after the inflammation. So we have a negative development with fibrosis happening in these patients. So the treatment we use now does not prevent fibrosis, and in that way it also increases the risk of residual kidney damage if we can't save kidney function as much as we would like, and there is a high risk of end-stage kidney disease in these patients. In UVA's trials, up to 50% of patients ended up in end-stage kidney disease within 5 years. So there's an interest in addressing this development of fibrosis, and there is an ongoing trial right now looking at this and adding a Claudin 1 antibody to patients with ANCA vasculitis who have received standard of care induction, and they're supposed to be treated within 4 weeks with this Claudin antibody that has antifibrotic properties. And this is an early phase 2 trial, but they're blinded, so we don't know who gets this experimental drug. So right now, I think we have a little break in this trial because they're assessing the first 20 patients to see what happened to them. And then we hope that we can continue including patients in this trial. So the guidelines that have been updated last year, and it's interesting, the treatment suggestions here from KDIGO is after diagnosis of ANCA vasculitis, you want to induce remission, and the suggestions for treating, it's rituximab plus glucocorticoid taper or avacopan, cyclophosphamide plus glucocorticoid taper or avacopan, or rituximab plus cyclophosphamide. So here they suggest that you also can combine rituximab and cyclophosphamide. And this has never been done in a randomized trial, but there's a fairly large patient cohort that has been treated this way in order to reduce the exposure to glucocorticoids. And it seems fairly successful. And here it says that you should consider plasma exchange, which I will come back to again very soon. And when you reach this disease control on drug, you switch to maintenance, and you could either continue rituximab or switch to azathioprine and taper glucocorticoids and continue with this, and then off-drug remission. So here it's clear that KDIGO believes that you should reduce glucocorticoids based on the Pexivas trial, and you should do it quite early on. So you may start with 1 milligram per kilogram, but within a week you should give 50% of that dose and then taper it. Here it says avacopan may be used as an alternative to glucocorticoids, and that here they also point out the low eGFR, the GFR recovery that is important with avacopan. So back to plasma exchange, I already showed you this, and that there were fewer serious infections with this low-dose steroid protocol. But this is also a recent publication to look at the kidney function in the Pexivas trial. And this trial showed that plasma exchange actually improves early kidney function in ANCA vasculitis, which is maybe something, we have a feeling that that's the case, that's something extra. But of course, there is an increased risk of infections using plasma exchange. So you really have to balance what you're after. And as long as if you have avacopan, maybe that would be a good option. But sometimes I still use plasma exchange in patients who have rapid progressive glomerulonephritis. So this is just a sort of summary of what they suggest. That there is a reduction of kidney failure at 12 months in a meta-analysis, but there is a concomitant increase in risk of serious infections. So this is a suggestion for DaVita, who works in Johns Hopkins, that patients with who have AKI with required dialysis or with rapidly increasing creatinine and acute lesions on kidney biopsy, alveolar hemorrhage requiring mechanical ventilation, double positive disease with positive anti-GBM should always be treated with plasma exchange, and also refractory vasculitis. This is where you should consider plasma exchange. So what about maintenance therapy? So maintenance therapy has been studied in several studies, 3 from France and 1 more international trial, showing all shown the same thing, that rituximab is better as for keeping maintenance than azathioprine or MMF. So this is something that interests me because I think we don't really know what to do. The maintenance therapy guidance is not changed in those current guidelines, and it says that the optimal duration is the 18 months to 4 years, which is not very precise. The relapse risk is, of course, high in ANCA-associated vasculitis, but not everybody relapses. So when should we really stop immunosuppression in ANCA-associated vasculitis? We have to balance immunosuppression, the efficacy and the side effects. And rituximab is, of course, has helped us a lot. It's good for relapsing disease, fertility, malignancy, and it's well tolerated, but infections remain a problem, and we see patients with late onset neutropenia and increased risk of hypogammaglobulinemia if you continue rituximab for a long time. And also the problem with vaccines, that you have a humoral immunodeficiency with this B-cell depletion. So that's a problem. So that's why I decided to start a study. It's called discontinuation of rituximab compared with rituximab maintenance in ANCA-associated vasculitis, and it's called DisRitux. And this is a trial that we're starting in Sweden and some EU countries and the UK. And we will include our first patient very soon. So we would randomize 140 patients. There will be 70 patients in each group. They will receive standardized fixed rituximab 500 milligrams or be discontinued. This will be not a blinded trial, so they will know if they are on rituximab or not. And they will receive it every 6 months, and we will follow them for 36 months. And then the primary outcome is the number of relapses in both groups. And we believe that we will have around 30% relapse in the discontinuation arm and maybe 5 to 10% in the maintenance arm. So this will be done, the randomization will be done through this REDCap system. And we will also, during the trial, collect research samples that we will analyze later, because the point of this trial is to find better biomarkers, so we to inform us, at least improve the possibility for us to know who is a high risk relapse patient and who is not. So, and then I just want to finish with a few slides about this group of patients with ANCA-associated vasculitis. Of course, they have this inflammation and kidney damage and all this, but they also have an increased risk of cardiovascular outcomes. And this is important that we consider that and that we treat our patients accordingly with drugs that can reduce this risk. So we know that albuminuria and CKD is, of course, associated to increase the cardiovascular disease risk. And the question is then, can we then improve kidney protection in ANCA-associated vasculitis after we have done with this our anti-inflammatory treatment? We'll have patients with CKD and with residual albuminuria and all that. And we have, of course, learned a lot in nephrology during the last couple of years that there are drugs that can protect kidneys better. And there's one trial looking at the patients with glomerulonephritis from mainly from Spain, but also some other sites, looking at almost 500 patients with biopsy-proven glomerular diseases. And in these patients, SGLT2 inhibitors were initiated on top of background RAS inhibitors. And they also then looked at the percentage reduction in 24-hour proteinuria from initiation up to 12 months. And they also looked at eGFR and other things. So here are all these patients, and they look very similar. So this is IgA nephropathy and IgA vasculitis before and after SGLT2 inhibition. This is ANCA-associated vasculitis. You also have a reduction in proteinuria and other inflammatory diseases like lupus. So it seems that there could be a role for SGLT2 inhibition in stable patients in remission with ANCA-associated vasculitis. So I actually started SGLT2 inhibition in a patient who's 27, I think, that had vasculitis when he was a child and has CKD around 40, and he has some albuminuria. And I thought, well, I guess he should be an SGLT2 inhibition as well. He's ANCA negative. So this is what he's treated with. So I guess it will be until his kidneys doesn't function anymore. So to conclude, ANCA-associated vasculitis patients are more prevalent because we have a high prevalence, even though the incidence is the same. So we have to think about that all these patients can relapse. And also patients who end up in dialysis can experience a relapse in their vasculitis. The new treatment guidelines are from 2024 and recommend different treatments, but it's quite clear that the low glucocorticoid induction treatment is the preferred one, that we shouldn't use these high steroid doses anymore. There are new treatments approved and in the pipeline, and these may change outcome and for our patients and also reduce adverse events. And also, I think it's important to treat residual CKD in ANCA-associated vasculitis patients. So I think that was my almost last. So we have now end of winter here. We really didn't have much of a winter, but today actually it snowed. But we are having early spring now, so we're looking forward to that. Well, yeah, I guess in Brazil, summer is ending, although you have always much better weather than we have. So I don't know if there is somebody wants to ask anything.
Yep, Renata. I want to first of all thank you very much for accepting our invitation for DaVita Brazil. So on behalf of DaVita Brazil, really want to thank you for this for enlightening this crowd. And yeah, we have a pretty engaged crew here, and they sent a couple of questions in the chats, and hope you can tackle these questions. So
all right,
Luis,
so but they're all in
I can
Portuguese. Yeah.
no
Yeah.
let me do the translation.
Okay.
So Louise asks, how do you follow up the maintenance dose for rituximab? Is it by a dose fix or from like a CD19 counts?
So we haven't, I think we stopped using CD19. So there have been trials looking at this, and it seems like the risk for relapse is higher if you use it on demand. So people usually give fixed doses at fixed interval. But I think that during COVID-19, we learned that some patients you could give them maybe every 9 months or something, and some are stuck on that still. But I hope that this District trial will help us a little bit, so we will have better biomarkers that we can use and that are not CD19. We of course check that also, but new biomarkers that will tell us that okay, your risk is very high. You should be on fixed dosing and continuously, where somebody has a low risk of relapse, and even if they may relapse, we can have give them some drug holiday based on better biomarkers. This is at least my hope that this will help us.
Oh, I understand. So we're hoping for biomarkers that can maybe guide more specific therapy, even though the patients are relapsing, right? I mean, you can target better therapy for those. That's pretty interesting.
Yeah.
Vanessa sent a little case, Annette. Do you mind?
No, it's okay. Somebody
It's
who's
okay?
74 years.
Excellent. Yep. So she mentions a male patient that's 74 years old, previously healthy, who developed a nephrotic syndrome with some nephritic components, and the kidney biopsy showed an IgA deposition and also evidence of vasculitis. And she first administered cyclophosphamide, and the patient maintained a creatinine level of 2 and proteinuria above 1 gram, despite therapies being optimized, all other therapies. And then corticosteroids tapering was initiated, and then now the current dose is 10 milligrams of prednisone. So she would like to know if you recommend progressing with rituximab treatments.
So this is an IgA vasculitis. Yeah. Okay. So I like using rituximab for IgA vasculitis. It's pretty easy, but sometimes before we use cyclophosphamide, and that wasn't bad. But I wonder what the biopsy looks like now. So if they could do another biopsy, that would be interesting to see if there is any activity, remaining activity. For IgA nephropathy as such, rituximab has not shown to be very successful. It's probably because it's not good enough as for B cell depletion. But for vasculitis, it's pretty good. So if it's possible, I would suggest a new kidney biopsy to see if there is any residual activity that is vasculitic. And if there is, you could try rituximab. If it isn't, I would suggest more optimized reduction. To work on the proteinuria, if the patient is not yet on SGLT2 inhibition, you could add that, for instance.
Excellent. And another question from Marcelo. It's in English, but I can relay it to you. Considering ANCA-associated vasculitis relapses in patients with reduced GFR, which one is preferred to address flares, proteinuria or increase in creatinine levels?
The question, I'm not sure I completely. Any flare.
I think it's like more like a diagnostic kind of approach.
Okay, diagnostic.
Yeah.
Okay. So the risk for relapse seems to be higher in patients who have hematuria that doesn't disappear compared to proteinuria. But if you have a rising creatinine and proteinuria rising, it depends if the patient is ANCA positive or not, because we don't treat patients based on ANCA titers. They have to have more things. things going on. But if they were ANCA negative and became ANCA positive with a rise in creatinine and more proteinuria in combination with hematuria, I would think it was a relapse. If the patient is ANCA negative, then it's maybe not likely that they have a relapse unless there's something wrong with your ANCA testing. But I like to do biopsies just to see what is going on if I'm not sure. But creatinine rising is maybe a more severe thing than somebody who has some residual proteinuria that changes a little bit. But it's always complicated with these patients. You have to look at the whole patient and see if there are other symptoms and CRP and, what happens to ANCA and things like that.
Yeah. And that I was just curious from what you've just spoke right now about like rebiopsying patients. Can you give us like a primer of what you consider in order to rebiopsy a patient with like an ANCA vasculitis?
Yeah. So if this patient, I feel that the treatment is not very successful. There's some refractory disease, and what I have been giving is not working, then I would rebiopsy because I want to know if there's something still going on. I mean, that happens. That you start, especially now when everybody's using rituximab much more, and it's always sort of discussed that maybe it may be a little bit less efficient in the short term than cyclophosphamide is perhaps a little bit better, and maybe you would need plasma exchange or again induce them with steroids. So if I'm worried about the patient and I feel like this is not it's not typical, then I would rebiopsy. I would rebiopsy if I think the patient has suspect the patient has a relapse, but I'm not completely sure. And also if I want to change the treatment and I want to know if this patient is somebody that really has activity or maybe just chronic damage. That I think is important to know. But I
more
mean,
like a prognostic approach, right?
Yeah, like a prognosis. So I think that many rheumatologists, they don't biopsy the patient, but I think that it's important to know what you have in the kidneys so you know what to plan for the future.
Right.
And it's also very important for the patient.
Exactly. That's good. That's a good point.
Mm.
Yep. I think you tackled all the questions from the crowd, Annette, and also my curiosity. So I would like to really appreciate your time with us at DaVita Brazil. I think it was an excellent talk and gives us perspective from what's coming up in the pipeline for new drugs with RCT evidence, something that's we're always excited in the nephrology field. So yeah, thank you so much for being here. I know it's getting close to midnight over there, so I want to let you get some rest.
Yes.
All right,
it's okay.
Annette.
Yeah. So thank you very much for the attention and have a good evening.
Excellent. So do you. All right. Take care.
Okay. Bye-bye.
All right. Bye-bye.
Bye-bye.